Okay, so teaching we're going to cover in this session is point of care ultrasound and the shock protocol. How this works. This teaching session is going to cover the concept of shock protocol ultrasound. The best way to learn ultrasound is to do it hands-on. Therefore, the best way to use our afternoon teaching session will be for me to supervise you folks scanning and to have some discussion regarding the clinical application of this. To help achieve that, we've flipped the lesson round so that the preparation and reading work is done by you guys prior to the session. This video highlights what the protocol involves and the accompanying video demonstrates the areas we'll be scanning. There are a couple of papers to read that I've linked to that are really useful, and there'll be some questions on the day to check your understanding. So, what is point of care ultrasound? Really, it's an extension of your clinical examination. It's ultrasound to image certain areas to answer specific questions. Think of it as a replacement for your stethoscope to a certain extent. You want to know if there's fluid around the heart? Don't listen for muffled heart sounds. Put the probe on and look for the fluid. You want to know if there's a pleural effusion? Rather than listen for reduced breath sounds? Or is it fluid? Is it air? Put the tubes down, put the probe on. We all know the advantages of ultrasound. It's quick, it's repeatable, and there's no radiation. It's a rule-in test, but what it's not is a replacement for a formal ultrasound examination or a formal echo. This is important because although you may understand this, the specialties taking over the care of the patient may not. They may well say, well, the ED echo looked fine, when in actual fact the ED echo showed no signs of pericardial fluid, septal bowing or obvious dysmotility, but didn't formally assess the valves or quantify ejection fractions, etc. And this is why a written report, which we'll cover at the end, is so important. So, what is shock protocol ultrasound? It's expanding your ultrasound practice from some of the basic principles you learnt in becoming level 1 competent to putting together a collection of individual examinations that can be easily learnt into a protocol to identify some of the causes of undifferentiated hypotension. So a quick recap, causes of shock. Really, most of you will know this by now. Hypovolemic, bleeding, cardiogenic, obstructions, included PE, tamponade, tension, HOCM, dysmotility due to an MI, distributive causes, anaphylactic, septic, neurogenic. So we know the causes of shock, we've just got to try and find ways of identifying them quickly. A lot of the stuff that when you're reading around this and what may use as we're teaching this is the concept of, rather than saying shock, of undifferentiated hypotension. It's hypotension where we're not sure what the cause is and we want to find out. So, a better way to use a case to try and use this as an example. So, the red phone goes, it's the ambulance crew on the other end. There's a 65-year-old female, she's got a pot on her right leg, sudden onset of shortness of breath, chest pain, fever last night though, both legs are swollen and the right leg looks erythematous. Pulse rate's 120, BP's 87/40, SATs are 85% on room air and the temperature's 37.8. Resus in 5 minutes please, what are you thinking? Well, hold those thoughts until we've gone through, expanded on this a little bit. So, what is the shock protocol? Have a read of these two papers. This is the whole point of using a video. You can press pause now, stop listening to me going on, and check out these two papers. Have you read them yet? Good. Right then. So, what's new? Taking this beyond level 1. Chest examination, echo examination, and some DVT scanning. So, echo is dead complicated, the heart's beating really fast. Not necessarily. We're going to go in and we're going to try and answer some specific questions. We're going to look for tamponade, we're going to look for right ventricular strain, and we're going to see if the left ventricle appears to be beating well all the way around or appears to be just flapping about in the wind. Ideally you need 2 views, one of which needs to be a 4-chamber view. The easiest one, and the one that you're probably most familiar with from doing the level 1 scanning, is the subxiphoid view, so use that one. It's a very good view. You get to see the right hand, all 4 chambers, and can have a look for any septal bowing very easily. Second view will be the ones that are more difficult and a little bit new to you. So we've got like parasternal long axis, and this looks primarily at the left ventricle and the left ventricular outflow tract, and you get a good look across the mitral and aortic valves and look at what the LV wall is doing. The other one is the parasternal short axis, which looks down into the left ventricle, then up to the mitral valve and up again through to the aortic valve. You can attempt to look for an apical view if you're unhappy, but this can be quite tricky, and hopefully you've got your 4-chamber view by doing the subxiphoid view. Take a look at this website. It's a really good website for correlating the anatomy and the findings that you can see on echo as to what you're looking at in each of the above views. Ideally, echo is performed using a phased array probe, which we don't have on our machines in Leeds. We've got tight curvilinear probe, but the main problem with that is that its tight radius limits the surface area of the probe that can be in contact with firm structures such as the chest wall. It's worth trying this though, as the images still can be very, very good and probably better than with the standard abdominal probe. Going on to the chest, the main question we want to answer is there a pneumothorax? What we're looking for is the absence of lung sliding in B&M mode. Don't get air and fluid mixed up. Remember, if there's air in there and it's a pneumothorax, you won't be able to see any lung beneath because the ultrasound doesn't transmit through the air. If you can see lung floating around in there and it looks to be moving with every breath, then the good chances are that there's a pleural effusion in there, not a pneumothorax. Correlate it clinically. Currently, you can't use the ultrasound to quantify the size of the pneumothorax to guide on chest drains, etc. in the same way we use chest X-ray at the moment. But that's not the point. That's not what you're looking for. You're looking for, is there a pneumothorax which may be under tension in a patient in extremis, and if so, you're going to be doing a rapid decompression on that patient. Fast and aorta, well, I'm not going to spend too long looking at these because you should know how to do those, but we can recap in the practical session. In this scenario, it also includes looking for free fluid in the pelvis from a possible ruptured ectopic. The usual caveats apply regarding the fact that to see any fluid in Morrison's pouch, you need a couple of 100 mils and it may take time to accumulate. So the question to answer is there any free fluid visible in the abdomen or the pelvis? Does the aorta appear aneurysmal or not? The other one that may be new to you is to have a detailed look at the IVC. So are you familiar with looking at the IVC? If not, well, you probably should be. What can it tell us? Well, it can give us an idea about the fluid responsiveness and fluid tolerance of a patient. There's a meta-analysis as to whether IVC is good for looking at volume fluid status, which you can have a look at if you want by DIPSI, that was published last year. And basically, you're using the IVC diameter and the IVC collapsibility index, which is the amount it collapses with respiration, which can correlate to CVP. And more than 50%, you're probably going to suggest that they're underfilled and probably going to be needing to be given a fluid bolus. So if you see the IVC collapsing down with each breath, get some fluids in. Equally, if it's bulging at the seams with no respiratory variation, consider if the patient's overloaded or if there's a clot somewhere upstream. Just beware of tricuspid regurgitation and pulmonary hypertension, as these patients may have a dilated IVC anyway, and so it's not really as much use in these cases. Looking at femorals, so looking for clots. You want to have a quick skim for clots. You've looked at the right ventricle on your 4-chamber echo view. Was the septum flattened or bulging into the LV? Is the IVC dilated? Could there be a big PE in there? Next place to look is down at the femorals. Using the same place you'd looked when you were placing a femoral line, have a quick look, identify the vein, and check to see if it can be fully compressed. Scan up and down a little bit to include the saphenous junction, and if you're really concerned, you can go down to the popliteal vein. Basically, find the vein, compress it down with your probe. If it doesn't fully collapse, then be concerned about a clot being there. So how does all this fit into our assessment? Well, it probably takes around 10 minutes, including ultrasound machine warm-up time, to do the scan. And you can do it as part of your primary survey for a patient coming into resus who's unwell. As usual with ultrasound, positive findings are positive, and negative findings don't completely rule out, but they do lower your suspicion. The commonest finding I've come across is that the patient needs volume resuscitating, but in the last year I've decompressed pneumothoraces, had a patient taken to theatre for cardiac tamponade, and thrombolised someone based on positive findings on the ultrasound. I've also really pushed fluids in a couple of septic folk who had collapsing IVCs. You need to consider a couple of other diagnoses, however, that may not necessarily show up on the ultrasound. So things like a GI bleed, it's probably also worth doing a PR in these patients. Pancreatitis, you may not necessarily see anything on the ultrasound. Or patients who are having an adrenal crisis, especially if those are on long-term steroids, your shock protocol ultrasound scan may be completely normal, and yet they still appear to be hypotensive. So when you're writing reports, and this is something I'd like to get you all to think about when performing scans more, the format should be in the same format as those we read from radiology. So there should be an indication, e.g. back and abdominal pain, pulsatile mass, hypotensive. There should be some findings, including the areas examined. So the abdominal aorta has been examined from the celiac axis to the bifurcation and reveals an abdominal aortic aneurysm with a maximal AP diameter of 7 cm with free fluid visible in Morrison's pouch. There should be some conclusion and advice to the specialties. So findings are consistent with a leaking abdominal aortic aneurysm. Vascular surgery opinion has been requested. And for shock, we need to list the areas examined and the findings, and we'll go through this in a bit more detail in the practical session. So back to the case, things to consider. The shock scan shows a big right ventricle with non-collapsible right femoral vein. What are you going to do now? Are you going to thrombolyse them? Are you going to low molecular weight heparins? It's added to your clinical picture. The shock scan shows no evidence of right ventricular strain or clot in the right leg, but a collapsible IVC. They've got a temperature, they've got a red leg. Is it just sepsis and cellulitis? Or based on that, would you exclude a PE and therefore would you forget about giving them any heparin? Just something to have a consider. Hopefully not to the last question, and you're still going to consider that PE could be there because we haven't excluded it, but this is a rule-in tool, not a rule-out tool. Probably still need to go looking for that given the clinical presentation. The shock protocol shows cardiac tamponade. Do you go straight in with the needle to drain some blood? Maybe worthwhile going down to scan, making sure you've scanned the rest of the aorta and that you've checked for any dissection. Does a shock protocol ultrasound improve outcome? Not currently proven that it does in the literature yet. However, there is a study out there which is called the Shock ED trial, which is looking to answer this. What it's really trying to do is to quickly provide you with more information than non-invasive observations alone to add to the overall clinical picture. This should be helpful in guiding your management. Try it and see how it influences your confidence and guides your management. I struggle to think how I had any idea what was going on in a cardiac arrest scenario before I took an ultrasound machine to each arrest. So where can you learn more? You've heard me chatter for 10-15 minutes. Now it's whet your appetite. Where can you go and learn more about this? Good starting point is the Northeast Medical Ultrasound Scheme Level 1 course. It's kind of a Level 1 plus course and goes through some basic echo allowing you to do shock protocol. There are individual echo courses available throughout the country, which you can go on and just for that specific component. And in terms of books, the Manual of Emergency and Critical Care Ultrasound by Noble and Nelson, second edition in 2011, is a really great book for medical ultrasound and pretty much goes through anything you'd want to ultrasound in the ED. If you have any questions before teaching, please let me know and I'll try and help. Otherwise, I'll see you at the teaching session and then we can get scanning.